Welcome again, my friends. So today this will be our final discussion on ischemic heart disease, which is part 4. Okay, and in the next lecture we will be continuing with like some other topic, congestive heart failure or congenital heart disease, depending upon the comments which I will be receiving. Okay, so you can share it in the comment section which topic you need. So in this topic we will learn about evolution of morphological changes in MI and its complications. As you know, in the last topic we had discussed in detail, in depth about myocardial infarction, what is the definition of that, what is the pathophysiology, and also the clinical features, risk factors, treatment, as well as some investigations I had discussed. Now in this we will discuss about the morphological changes, that is the what are the microscopic changes and what are the macroscopic features, that is the gross features in myocardial infarction, and what are the complications of MI. And along with that, other two types of ischemic heart disease, that is sudden cardiac death and the chronic ischemic heart disease, we will be dealing now. Okay, so going to our morphologic features. For some time I will remove my video. Okay, now this is the table which is given in Robbins, and it is a huge table, hectic table to study as well as to understand. Some students usually find it difficult to study this, right? So I will try to simplify this as much as I can, okay, so that it may be helpful for you to retain in your mind for a longer period of time. So before reading this big table, huge table, let me give you a short brief about ischemia. As you know, suppose this is the blood vessel and this is the heart, right? And here you have that occluded blood vessel. The atherosclerosis plaque is actually occluding the blood vessel, and thrombosis had occurred which has totally occluded the blood vessel. Now the blood flow cannot pass through this blood vessel, leading to the myocardial infarction. This you know. Now this ischemia, what it does? Initially, first ischemia occurs, you know that, right? Now if this ischemia persists for some time, what happens? That irreversible injury occurs that leads to necrosis. So necrosis occurs, you know this, in myocardial infarction, and after this necrosis, you know, in general pathology, necrosis is usually followed by inflammation, because in necrosis all the cellular debris as well as the dead neutrophils, that all will be released into the circulation, and the bystander surrounding cells also get inflamed. Whereas in case of apoptosis, it is a programmed cell death where neighboring inflammation does not take place. Whereas in case of necrosis, neighboring inflammation takes place. And so this necrosis will be followed by the acute inflammation, AI, that is acute inflammation occurs. And in acute inflammation, you know what will be coming first? Neutrophil infiltration occurs. So initially there will be neutrophils will come, and this will be followed by macrophages. Okay, so these both together constitute the inflammation part. Then after inflammation, what will happen? Obviously healing will start, healing process will occur. So what happens? Granulation tissue formation will occur. GN, I am writing GN, that is short form granulation tissue. What happens here in granulation tissue? There will be angiogenesis, VEGF, vascular endothelial growth factor multiplication, and angiopoietins 1 and 2. These things will all lead to the angiogenesis along with the proliferation of fibroblast, so that leads to the deposition of collagen. And after this will progress to a scar formation. So this is the microscopic changes which will occur in sequence. First, ischemia occurs due to occlusion of the blood vessel that leads to necrosis, irreversible damage to the heart in the form of myocardial infarction. And following this necrosis, what happens is the acute inflammation takes place in the neighboring cells, that is neutrophils as well as the macrophages come into action. And following this, there will be formation of the granulation tissue due to proliferation of fibroblasts, and then it may progress to scar at final stage. Okay, this schematic figure you should know, you should keep it in mind, and if you want you can write in your note for revising in the future. Okay, so keep this in mind. We will go to the table now with this information. Now I will be removing the video for some time. Yeah, just try to concentrate in this picture that is in this table. So here the heading is evolution of morphologic changes in myocardial infarction. Here you have gross features, microscopic feature, that is the light microscope, and electron microscope. Electron microscope we don't need now. Okay, We will discuss mainly about the light microscopic features as well as gross features. And here time. This time refers to the time after infarction. That means how much time had occurred after the infarction. If you see here, initially there will be reversible injury due to ischemia. In this there is 0 to half hour. There will be no gross features and no light microscopic features. That means in case of stable angina as well as unstable angina, there will be no features of no macroscopic as well as no microscopic features you will see. This is simple as that. Now coming to the irreversible injury, that means when necrosis had occurred, that means myocardial infarction had occurred, half to 4 hours, there will be no gross features. Okay, can you see here? No gross features. Whereas in microscopic features also there will be none, usually none. Keep this in mind. This variable waviness of fibers, this all we don't want. Okay, just keep it in mind. In irreversible injury, up to 4 hours after developing myocardial infarction, there will be no microscopic nor gross features. Now, after 4 hours, that is 4 to 12 hours period, in between this 4 to 12 hours period, the light microscopic changes will be coagulative necrosis. As I said you, following ischemia, necrosis develops, and this necrosis will be in the form of coagulation necrosis. You would have learnt in general pathology what are the patterns of necrosis. There are approximately 4 or 5 patterns of necrosis. It is an important 5-mark question also. You have coagulation necrosis, you have liquefactive necrosis, fat necrosis, gaseous necrosis, etc. So in this condition, coagulation necrosis, what happens is the cell membrane gets preserved, whereas the nucleus get lost. The organelles which are present in the cell will be impaired, gets disrupted, whereas the cell architecture gets preserved. That is the definition of coagulation necrosis, and it occurs in ischemia of almost any organ of the body. Let we take liver, let we take heart, let we take kidney. In every organ, if ischemia occurs and if it is followed by necrosis, and that will be the type of coagulative necrosis. Exception is that is the brain. In brain there will be no coagulative necrosis, there will be liquefactive necrosis. Okay, ischemia of the brain will lead to liquefactive necrosis, not coagulation necrosis. Okay, so this is a heart. Here we will develop coagulation necrosis, obviously. Edema and hemorrhage are associated features. No need to know about that. Just keep it in mind, early coagulation necrosis occurs. And following this, 12 to 24 hours, you can see here, 12 to 24 hours also coagulation necrosis occurs. That is the main point here also. So keep it in mind, 4 to 12 and 12 to 24 hours. That means from here to here, together consider as it 1 day. That is 1 day. From 4 hours to 24 hours, within 1 day, you will develop coagulation necrosis. Okay, and then gross feature which will accompany this condition is dark mottling. Less than 4 hours, there will be no changes, whereas from 4 hours to 24 hours, that is 1 day, you will develop coagulation necrosis. And after that, 1 to 3 days. In 1 to 3 days, the coagulation necrosis had occurred. After necrosis, what will happen? Obviously, acute inflammation starts. So there will be brisk interstitial infiltrate of neutrophils. That means neutrophils had start coming in. Okay, then following this 3 to 7 days, you will have macrophages. You can see here macrophages. I am drawing this macrophages. Only this thing you focus. No need to read everything. Just focus on the words which I am highlighting or which I am encircling. Okay. So 3 to 7 days macrophages comes in. So initially neutrophils will come in and start the acute inflammation process, following which the macrophages comes and it will eat all the debris, all the cellular debris as well as dead neutrophils. Everything will be eaten up by this macrophages. So from first day to 7th day, that is 1 week, you will develop inflammation, and during this inflammation stage, initially you will have mottling with yellow tan. In fact, so yellow tan, this color is given because there will be destruction of the neutrophils and destruction of the cellular debris that lead to the pus formation, which may cause this yellow tan in fact center. And as the macrophages comes in, this central yellow tan softening will enlarge. It will be more yellowish color, and hyperemic border may occur. There is a reddish border can develop. This much, you know, that is more than sufficient. Okay, now I will remove these annotations. Yeah, now coming down, we had seen up to 3 to 7 days. Up to here we had completed. Now coming to this 7 to 10 days, what happened? In 7 to 10 days, there will be well developed phagocytosis of the dead cells. So in this condition, in 7 to 10 days also, the macrophages is eating the dead debris. That means there will be yellow tan, soft, with depressed red tan margins. The same thing here also, the macrophages are still continuing to eat the cellular debris. So from 7 to 10 days also the same thing occurs. Then after this, remember after this, after 10 days, that is 10 to 14 days, what happened is well established granulation tissue formation occurs. You know, after following the inflammation, granulation tissue occurs due to the synthesis of blood vessels, that is angiogenesis. Angiopoietins 1 will be released, as well as your fibroblast gets proliferated, that leads to the collagen deposition. Here you can see collagen deposition, blood vessels, everything will lead to the granulation tissue formation. Okay, then following this 2 to 8 weeks, again there will be this collagen deposition will increase, leading to this scar formation. You can see here gray white scar, right? And greater than 2 months, after some months, scarring gets completed and dense collagenous scar formation occurs. So this is the table which I had tried to simplify. I will make a new table regarding this so that you can get idea. So initially there will be ischemia, which leads to coagulative necrosis, and following necrosis inflammation occurs by infiltration of neutrophils, that is followed by the macrophages, and after this healing process takes place in the form of granulation tissue, and then scarring gets completed finally. Observe keenly here, okay? Initial 4 hours there will be no gross features and no microscopic features. I will discussing mainly microscopic features, okay? Nothing will be there, nothing will be seen here. Now within 1 day, 1D means that is within 1 day, what microscopic feature you will see? Coagulative necrosis, and in case of gross features, some mottling you can see. Okay, this is practically not possible to visualize the heart. You cannot take the heart from the living patient, right? It may be seen after doing autopsy of a dead patient who had suffered from MI. And this is 1 day you will see coagulative necrosis. In 1 week, within 1 week, you will see acute inflammation and neutrophil infiltration will occur. Okay, here neutrophil inflammation will occur. Now 2 weeks, within 2 weeks, macrophages will come into action. M means macrophages, and it will eat up all the cellular debris, dead neutrophils, everything will be eaten up by these macrophages. And 2 to 8 weeks, what happens? What will come? Granulation tissue formation occurs, GT, granulation tissue. And after 8 weeks, that means some 2 to 3 months after this, complete scarring take place. So this is a short box, you can say, even though my handwriting is little bit weak as I am writing in the phone directly. If you want, I can write in a paper and I will send you the screenshot. What in short, within 4 hours there will be no changes. In 1 day you will develop coagulative necrosis approximately within 24 hours. In 1 week you will have neutrophil infiltration, 2 weeks macrophage infiltration, and 2 to 8 weeks granulation tissue formation. Finally scarring occurs. So I had tried to simplify this huge hectic table as much as I can. You no need to remember this electron microscope, just remember the gross features as well as the light microscopic features based on the information what I had given. That's all. Got it? So we had completed this morphological features. Now this is also taken from your Robbins book. You can see here. Here one stain is used, which is actually here you can see triphenyl tetrazolium chloride. I am highlighting this. You can see here there is a pale whitish color area which is situated here. This is the area of infarction. Okay, this area had undergone myocardial infarction. The principle of this test is, if you put the triphenyl tetrazolium chloride on the specimen of the heart which has suffered MI, myocardial infarction, these are all the normal myocytes. And normal myocytes has an enzyme that is lactate dehydrogenase in the cardiac myocytes. So these cells which has the lactate dehydrogenase enzyme, they will actively take up this triphenyl tetrazolium chloride stain. It appears red in color. Whereas this case, as it has irreversible injury, that means it had undergone infection and irreversible injury had occurred, so all the enzymes had been leaked out from this cell along with the lactate dehydrogenase, and so this area, this damaged cardiac myocytes now cannot take up this triphenyl tetrazolium chloride stain and pale area occurs. So by this technique you can visualize which particular area of the heart has undergone infarction. Got it? Yeah. Now coming to the complications of myocardial infarction. Here you can see This is a simple one. If a patient who suffers from the severe chest pain and develops the myocardial infarction, he may undergo cardiogenic shock or congestive heart failure, or he may land up in arrhythmia. Okay, and one more complication, important complication, fibrinous pericarditis. I had given some of the complications only which are main. There are a lot of complication in your Robbins book. You can read that, you can go through that, but still this complication you should never forget, you should not forget. Okay, so what is fibrinous pericarditis? Suppose, let me draw here. Suppose this is the heart. It has 3 valves, and this is the pericardial sac. Yes, that is pericardial sac I am writing. Now what happens? Myocardial infarction is a transmural MI. All 3 layers of the heart get involved. So here MI had occurred. Following this MI, what happens? Coagulative necrosis occurs, and then due to coagulative necrosis, following which active inflammation occurs. So neutrophils, macrophages come in, as I said you before, and now these neutrophils and macrophages will eat up all the cellular debris, and some reactions will take place. A heated battle will occur between the neutrophils and the damaged cardiac myocytes, and this led to the release of this dead neutrophils, cellular debris, everything into the pericardium. So what happens? These cells get breached through these 3 layers of the heart and comes into the pericardium. Now as it comes to the pericardium, it may start inflammation here. So acute inflammation occurs in the pericardial sac. This is actually called as fibrinous pericarditis, inflammation of the pericardium. Okay. Now this complication we had seen. And in this condition you may hear the pericardial rub. One more is rupture of the ventricular wall, rupture of papillary muscle, and rupture of interventricular septum. Suppose, you can see here, suppose this is the heart, and if rupture occurs here, that is the ventricular wall, free ventricular wall gets ruptured, then what happens? Obviously, the release of the fluid, this pus and the fluid, cellular debris, neutrophils, macrophages, everything will be released into the pericardium, surrounding pericardium. And as more amount of pus and more amount of neutrophils, cellular debris comes in, then it will cause cardiac tamponade. It will compress the heart, leading to cardiac tamponade. Okay? If suppose the same heart, ventricular wall is normal, but there is a rupture of the interventricular septum. Okay, suppose this is the ventricle, 2 ventricles, this is the left ventricle and this is the right ventricle. Interventricular septum gets damaged, then what happens? There will be shunting of the blood. It may go from right to left, or it may come from left to right, depending upon the constant, depending upon the pressure gradient. Right? Suppose this is the heart, and now there is a rupture of papillary muscle. Here you have the mitral valve. This is the mitral valve, and this is the papillary muscle, which is connected to the mitral valve through the chorda tendineae, which allows the movement of mitral valve to open and close. Okay, now this papillary muscle got ruptured. What happens? The mitral valve integrity, structural integrity is lost. It may not be able to open and close properly, leading to mitral insufficiency. That is, mitral regurgitation state-like condition is created now. So if the preventricular wall is ruptured, then what happens? It may lead to cardiac tamponade. If the interventricular wall gets breached, then right to left shunting or left to right shunting will occur depending upon the pressure gradient. And if the papillary muscles get ruptured, then mitral valve insufficiency occurs that leads to mitral regurgitation. Okay, so these complications get completed. Now coming to the 4th complication, which is the aneurysm. You know that finally, after healing process gets completed, scar formation occurs, right? And now this scar is very fragile. It's not healthy, it's not strong, it does not have the structural integrity as that of the heart muscle. As the scar is so fragile, it may break off, or it may weaken the wall of the heart, which leads to the formation of aneurysm. And also other condition is the mural thrombus formation occurs, and also Dressler syndrome. What is Dressler syndrome? In Dressler syndrome, you know, this is the heart, this is the pericardial sac, and the neutrophils, every debris, cellular debris, everything comes into the, due to the rupture of the ventricular heart or something, inflammatory products comes into the pericardial sac, you know. It may cause fibrinous pericarditis, or it may cause cardiac tamponade, or sometimes these products may activate the immune system of the body. If it activates the immune system of the body, the immune system will generate a response by secreting lot of antibodies against these products. Now these antibodies will come in and it will further activate the inflammation and further deteriorate the conditions of the patient. Okay. So this is one more complication you should know. Short recap: in complication, you have the cardiogenic shock, CHF, or arrhythmia. Or it can be in the form of fibrinous pericarditis, where the inflammatory products, cellular debris will come into the pericardial sac, leading to the formation of fibrinous pericarditis. Or there can be rupture of the ventricular wall, which leads to the cardiac tamponade, or it may be rupture of papillary muscles that may lead to mitral insufficiency, or there may be a rupture of interventricular septum that lead to right to left shunt or left to right shunt. And finally, there may be aneurysm formation or the mural thrombus, or there may be a cause of Dressler syndrome, where autoimmune reaction occurs to these inflammatory products that will deteriorate the condition further. Okay. Now, we had completed the morphological changes that occur in the myocardial infarction as well as the complications of myocardial infarction. Now, going to the another type of ischemic heart disease, which is the chronic ischemic heart disease. What happens here? It is a progressive heart failure due to repeated or recurrent previous MI episodes. That means a patient who had repeated or recurrent previous myocardial infarction episodes, he may land up in heart failure in future at some stage, at some time. Okay. Now, what is the pathophysiology behind this? Why a patient who is getting recurrent previous MI episodes should land up in heart failure? The reason is, suppose a patient who is suffering again and again from MI, you are treating him with those medicines like what to say, beta blocker, angioplasty. Again the patient is developing MI, again you are treating, and again he develops MI, so that recurring MI episodes had occurred in this patient. Okay. Now what happens, as recurrent episodes had occurred in the first MI, there may be some 10% loss of myocytes. Some here, this is 10% loss of myocyte had occurred. And you know, cardiac myocytes cannot regenerate. They don't have the ability to regenerate. They are the permanent tissues. Only hypertrophy is possible, but not hyperplasia. That also you know. So 10% is lost. 90% remains healthy, so no problem. Again the patient develops MI. Then again some 20% is lost. And you are again treating the patient carefully. The patient recovers. And again third time he develops MI. So again some 30 to 40% is lost. So remaining 60 to 50%, okay, keep it as 50% only. This 50% cardiac myocytes are normal now in this patient. This cardiac myocytes should compensate this loss. Okay, how it can compensate? Not by hyperplasia, only by hypertrophy. So these cardiac myocytes, the remaining cardiac myocytes which are non-infarct healthy myocardium, they will undergo hypertrophy. As this hypertrophy occurs, the demand of the heart is also increased. The oxygen demand, the blood supply demand is also increased. But the blood supply is limited, it is restricted. So demand perfusion mismatch occurs. And that leads to the development of chronic ischemic heart disease. So the main pathophysiology behind this chronic ischemic heart disease is that due to the hypertrophy of the heart, which is a compensatory mechanism for these dead myocytes, the demand of the heart increases, that leads to chronic ischemic heart disease. Okay, so you can see here the pathophysiology: due to repeated MI episodes in the past, hypertrophy of the intact myocardium occurs, and so the demand perfusion mismatch, that means the demand of the heart increases but the supply is not increased, that leads to demand perfusion mismatch. As these cardiac myocytes will undergo dysfunction and the patient may land up in heart failure at a final stage. Okay, so chronic ischemic heart disease means he may develop heart failure, or progressive heart failure is occurring due to repeated or recurring previous myocardial infarction episodes. Got it? Now coming to our last and final topic of ischemic heart disease, which is the sudden cardiac death. What happens in this? It is an unexpected death without symptoms or with symptoms of less than 1 hour. What does it mean? Suppose a patient who is suffering from silent MI. Imagine he is suffering from the silent MI. One day he is sleeping at night, and in the middle of night he may develop this sudden cardiac death and he may get expired. And in the morning when his relatives are trying to wake him up, he may not wake up. He's already passed away. So like that it can occur, unexpected death without symptoms. This can occur, or sometimes with symptoms. The patient may develop severe chest pain, he's not able to walk, he's not able to talk, so the relatives try to take him to the hospital. They're calling 108 or 911 in perspective of US. Then what happens? Ambulance will take obviously some time to reach the required location. So within the time gap he may land up in death. That is sudden cardiac death. Okay, so either without the symptoms or with symptoms of less than 1 hour, sudden cardiac death can occur. Okay, and what is the pathophysiology behind this? It is not clearly understood what is the real reason behind this, but in your Robbins and most journals say that it is due to the fatal ventricular arrhythmia. If it is a case of ventricular arrhythmia, then we can treat it by giving defibrillation. It is a shockable rhythm, so we can give defibrillation by using automated external defibrillator and we can treat the condition. But if the patient has this fatal ventricular arrhythmia, which cannot be treated effectively, that may cause the patient to land up in sudden cardiac death. Okay, and this fatal ventricular arrhythmia occurs due to repeated previous MI episodes. See here also the reason is repeated previous MI episodes. So due to the previous MI episodes, either the patient may land up in chronic ischemic heart disease, which make him to acquire heart failure, or he may land up in this sudden cardiac death without symptoms at night, or it may be after developing symptoms within 1 hour he may get expired, right? So these are the two topics. It's not that much significant, but still you should know about that. So with this we had concluded our session of ischemic heart disease. Hope you enjoyed. Thanks a lot.